I think I will just get started and keep an eye on anybody sort of joining a little bit late. So I think some of you may know me, but my name, welcome to our webinar. My name's Lori Prue. I'm a part-time managing director with the Canadian Arthritis Patient Alliance. I live with arthritis too, live with the juvenile form of the disease, and I've also been a patient partner for close to 20 years now. Got started actually with the help of Linda many, many years ago, our esteemed speaker, Linda Wilhelm, and many others. I am recording this webinar. But I figured we'll see in terms of like there'll be some presentation components in that, but if there's anything sensitive or feel free to speak your mind, and we'll see about sharing that, any sort of secondary part beyond the presentations. So just wanted to let you know that, and we'll at the very least upload sort of the presentations to the CAPA website sort of for future reference, as well as our YouTube channel. So like that would be the part with Linda and Therese speaking. We'll be doing a nice like sort of takeaway resource. So we'll have it translated as well to French and made available on our website. So if there's anything that we talk about, resources, these sorts of things, like we're looking and we're going to be capturing that as we go along. So just wanted to let you know. So yeah, feel free to share things in the chat and that sort of thing, sort of in that vein. And of course, I invite you to add, questions in the chat, comments in the chat. I'll be watching for them as we go along. And I know many people have submitted questions, which I'll be using sort of for the Q&A portion of this. Also wanted to say, je parle également en français, alors j'invite donc à poser ces questions dans le chat ou come en français. So I also speak French. So feel free if you wish to sort of put that into the chat in French. I can do sort of the translation on the spot as well. But before we get too started, wanted to acknowledge that I live, work, and play on the traditional and unceded territory of the Anishinaabe or Algonquin peoples in the place known as Ottawa. So invite you to sort of reflect on that. We all come from different parts of Canada, so we all are sort of situated in different spaces with different nations. So feel free to sort of do that in the chat, or even just like think to yourself in terms of, where we're situated. And who has come and sort of taken care of this land for, years and hundreds of years and thousands of years before we've come here. In terms of the agenda for today, I'll spend a few minutes on the introduction. I'll pass it to Linda Wilhelm to present for about 10 minutes. This is super informal, so beyond my slides here, this is all that you'll see as far as slides. Presentation by Therese Lane as well, and followed by a very healthy question and answer period and a closing. So this is the agenda. Like I said, feel free to put your questions in as we go along. And I'll be monitoring this. And so, without further ado, I thought I would introduce, Linda Wilhelm, who I've had the privilege of knowing for so many years, really helped me get started and stay in this space, frankly, over the years, because I know it's hard and it can be discouraging. So, anyways, and I will pass it to Linda, who can sort of introduce herself as well. And then I'll kind of come back and introduce Therese after she's done talking.
Hi, everybody, and welcome to our webinar. And I'm just going to share a little bit about it. I started to get involved quite a few years ago, I think around 2000, after a pretty bumpy ride with the disease that we call rheumatoid arthritis. And there's many other different ones, but that was the one I ended up being the luck of the draw with. And I wanted to change the world. And at the beginning, I wanted to change the world for people living with rheumatoid arthritis. I just got tired of the healthcare system not understanding our disease. And I know others feel the same with fibromyalgia and ankylosing spondylitis. And, they don't understand the disease, and you just kept getting dismissed. And I was tired of everybody not knowing that it affects younger people. I was 23 when I was diagnosed. I was pregnant with a 1 year old. And, everybody, oh, you're too young to have arthritis. You can't have arthritis. They must have made a mistake. And just by the very fact that I was young, just dismissed that I could even have a serious autoimmune disease beyond not even having a clue what it was. And then I got tired of strangers coming up to me in public, and with all kinds of cures, that this was, like you could, if you just drank apple cider vinegar every day, you're going to be all better. If you just buy these $1,000 magnets, you're going to get all better. And just, it seemed at every turn, I was being blamed for this disease. When I was on, 10 different drugs in 5 year period that I failed. So I'm the failure on these drugs. That I did too much that day. I went for a walk, or I went Christmas shopping in the mall, and so I brought this on myself. I'm not taking, all these $300-500 worth of nutritional supplements every month. So if I'd only do that, then I would be cured. And so I guess for me, that it just, all these things together spurred me to just say, something's got to get done, something's got to give. And what gave was biologics. And we knew when they came out that it was going to be a long, hard battle to get them covered because of the price. At the time in 2000, they were the most expensive drugs that Canada had seen for a good, fairly large number of the population. So, we knew that they were going, but it also, what it did? It gave us a profile, because now all of a sudden government's looking, saying, oh, these drugs are $25,000 a year. They're not worth it. And then we could go, and I could go with my hands, and Lori could go with her hands. And we were young at the time, I was 39 years old, 40 years old, and say, yeah, these drugs are important because this is what happens to people who don't get these medications and don't get the appropriate treatments. So, we spent 3 years, with government trying to get them to cover the drugs from 2000 to 2003. And every province now lists these drugs, and there's criteria, and there are barriers, and there are still roadblocks. That's why I'm still here doing what I'm doing, trying to change the world for people living with rheumatoid arthritis. I got access to Enbrel in 1999, almost 2 years before it was approved by Health Canada, because I ended up in the hospital. I couldn't move. They didn't know what to do with me. I refused to leave until they did something to help me. I had, a 13-year-old, 11-year-old, and an 8-year-old at home at the time. And I'm not doing this. I'm not going home and putting them through this anymore. You guys need to figure this out. I know this drug's approved in the US, and how are we going to get it? 3.5 months later, I did get access to the drug. I met with government, I met with MLAs, I met with MPs, and just kind of laid it all out there, and sometimes bawling my eyes out, and getting my husband to carry me into a room because I couldn't walk anymore. And then they gave me the medication. But the caveat was I had to go home and shut up, or I would lose the medication. So I went home for 1.5 years and recovered, got my strength back because I had spent a year in a wheelchair before this, had 14 total joint replacements or fusion in about a 6 year period. So from 2000 to 2005, I went through surgery about every 6 months. And got myself back on track. And then I started advocating, and CAPA was formed in 2002. And I was one of the founding members, and just we haven't really stopped. And I think we've grown exponentially over the last decade or so. And we're trying to engage more and more people, trying to provide opportunities for more and more people. I spent 10 years in New Brunswick working on a catastrophic drug program that didn't exist. And I know people think these things happen. They didn't happen. We started with a progressive conservative government lobbying, lobbying, lobbying. They lost the next election. Then we started the Liberal government, lobby for another 4 years. And then they lost the next election. And finally, we got back to the PC government. And luckily, the leader, the premier at the time, was part of the previous conversations. And we got the catastrophic drug program, which allowed my husband to retire and me to get my medication. So there, even then, there was a bit of selfishness, but it is a good program. I think far better than some of the other ones across the country. There are still co-pays and there are still premiums. They're income based, but all in all, at least if you're under 65 living with a disease like this, you will get your medication. So that was a huge win, but I'm telling you, it's work. It doesn't happen overnight. And then I got involved in research through the Canadian Arthritis Research Network, who were very forward thinking, involved patients as partners in research long before the strategy for patient-oriented research came around. IMHA, the Institute for Musculoskeletal Health and Arthritis, has been a huge supporter of patient engagement in research. And then, we still have problems. I finally, we got research going on in New Brunswick, and that's partly straight thanks to the strategy for patient-oriented research. But I'm in with University of New Brunswick, involved with their Center for Research and Integrated Care. I never took compensation for that role because I was on disability and I could only make a certain amount. So once I turned 65, I inquired about compensation. And I'll tell you, the process took me 3 hours to navigate, to get signed up. And that doesn't even now, then I had to go through another 2-hour process to be able to access research documents. So, we still have a lot of work to do when we have universities, and then they're not the only one. I'm calling out UNB on this, but I mean, they have tried to help make the process easier. They have tried everything. It's just, they make you become an employee and everything that goes with that. So we still have work to do, but I think, we're improving it. We're getting there. It's, if I look back the last 2 years, I could get frustrated. If I look back at the last 20 years, I guess I feel really good about what we're doing. So, and I'm going to turn it back to Lori to introduce Therese.
Well, thank you so much, Linda. I think you, yeah, I know a lot of strength and tenacity, and it really shows how we all, and I know I could speak from myself, right? We sort of start from a point of frustration, right? And wanting to do something about it and just sort of suffering and continuing to do, live our existence, hoping to do better for others. So thank you for that. I'm going to pass it over now to Therese Lane, who I've been happy to know, I guess, for at least 5 years or so now. She's on the CAPA Board of Directors and is also an amazing person to work with, and really happy to sort of pass the stage or pass the to you, Therese. So thanks so much.
Thank you, Laurie. And it's actually been 7 years. Time flies.
Time flies, absolutely.
Yeah. Hi, everyone. I'm Therese, and I have lived with chronic pain due to many forms of arthritis since my teens. I think I grew up not really knowing where I fit in life. Always felt different to other people, which led me down a path into addiction, mental health issues, and came out the other side, fortunately, but learned a lot on the way. I came into patient engagement in the most unexpected way. I had part of a treatment program that I was on. I started going to the YMCA and noticed that on the days that I attended the YMCA and talked with different people, that I felt better, not only mentally, but physically too, from moving around. I had been really depressed, that my body was, seemed to be screaming at me all the time. And I found that just gentle exercises has been amazing for me. But anyways, I mentioned to somebody who I worked out with that I had pain, and she is a researcher who really involves patients in her research. So she opened a door for me about everything that followed. She signed me up with everyone she knew, and but the main thing that happened to me was I became um, a patient partner with the Sport Chronic Pain Network. From there, I met a few of the CAPA members, Linda and Dawn and Janet, and joined CAPA in 2018. So yeah, and it was there basically that I found my voice. I got involved in research. My first project was with a basic scientist, so it was very awkward. I didn't know what I was doing. He didn't know what he was doing, but we muddled through it anyways. I have since been involved with many different projects, and the one that I'm doing at the moment, I started out as a participant. It was through a clinical trial when I was having treatment for breast cancer, and I had to have some surgery, and they asked me if I would be willing to try lidocaine, which they were testing to see that it could prevent long-term relief. It prevented chronic pain following breast cancer surgery. So I was thrilled about that. I love the idea of prevention, and I was only too happy to join. After that, by some kind of strange way, I ended up on their advisory committee, and have been very involved with patient engagement there. They've been wonderful. This is the first time this team has had patient partners, so there was a learning curve for both of us, really, but they were very willing to learn, and it's been exciting, and we've done many things together. I've done an outgoing video to promote participation amongst potential clinical trial participants. So, and also did a video to encourage the team to carry on because it's almost finished now. So yeah, so what else is there? So there's been many challenges. One of them is the compensation. And not just if patients are paid, but how and when. I find with some that the process can be very complicated or slow. And to me, that sends a message that we're not fully there and that we need to do some work. Another challenge for me has been learning to find my voice. There were moments when I wondered whether my lived experience really counts as expertise. But over time, I've learned that it does. Lived experience brings a kind of knowledge that is grounded in reality. We bring a face to what is going on, in the background to me. So, and because we know our bodies, we know what we go through on a day-to-day basis. So, yeah, you can't find everything in a textbook. So, yeah, so I was talking about the team that what they have said. We've talked about what I brought to them because this new team now have talked about they were afraid to bring in patient partners because they think that the bar is set so high. They were afraid that they do it wrong and everything. But I have found that being open and honest with each other, back and forth, that great relationships can be made, and that research becomes more relevant, more compassionate, and ultimately more impactful. So being a patient partner has taught me that good research doesn't happen in isolation. It happens in relationships, and it's not easy or perfect, but it's absolutely worth it. I feel I belong somewhere at last in my twilight years, and I'm truly grateful that I had that gym conversation. It started me on a path that I never expected. For me, patient engagement isn't about perfection; it's about partnership, progress, and the courage to learn from each other. Thank you.
Thank you so much, Therese. I think wise words for sure, right? Focusing on the relationship and and sort of sticking with it, even if there's some bumps along the road, right? You can always kind of go back to that. So thank you so much for being so open and sharing that and your lived experience as well. So a number of people are kind of shift now to the sort of informal Q&A portion, which we really wanted to give like a healthy allotment of time to that. So as part of the registration, I do have a number of questions, but that I can work from that I've heard from people. So we'll start with that, but like as we go along, feel free to like add in any questions in the chat. We can kind of work off those as well as we sort of go through things. So, all right, well, maybe I'll start with the different kinds of roles that you've both had. So I'll sort of address them to Linda and Therese, right? And I'm wondering if you could, I mean, you've talked a little bit about some of the things that you've worked on, but if you can go back, are there certain roles that you never knew existed or wouldn't have thought that maybe we, would be a place where patient partners would sort of get involved or patient perspectives could be shared, and that could be policy making, that could be research. So maybe I'll go to you first, Linda, if that's okay, and I'll just kind of go back and forth.
Sure. I'll talk about maybe the first time I had a role that I wondered about was way back in like 2001. The Arthritis Society had started engaging patient partners with the Canadian Arthritis Research Network in grant reviews. So I got asked to go to Toronto. This is when they were all done in person, and now they're not, which is even better. But when we had to go to Toronto to have this 2-day peer review meeting. And I didn't have a clue what I was doing. I just thought, okay, well, this is interesting. I'll go. And I went, and I was sitting there, and I'm thinking, like, they were discussing a basic science grant. And I'm like, oh my gosh, how am I ever going to know how to review this grant? I don't even know what it's about. And so I must have muttered something like that under my breath or whatever, and said, I don't have a clue what they're talking about or whatever. And the researcher beside me said, that's okay. He says, I'm a clinician. I don't have a clue what they're talking about either. And I thought, oh, okay. And then the next time I got asked to be part of, they were modernizing the drug review system. And I was pretty frustrated with the drug review system at the time because I had waited so long for Enbrel, which I got under special access, and took over 2 years longer to get approved in Canada than the US. And I was pretty worked up about that. And we had been working with the Arthritis Community Research Evaluation Unit in Toronto, and just published a book called Arthritis in Canada in joint publication with Health Canada. And I got invited to this drug review modernization consultation, so in Ottawa. So I went, and there were 2 patients in the room. One patient left because she had other meetings with MPs or whatever, and she just ducked out. And so I was there all by myself, trying to not let them know that I was an actual patient. So I'm hiding my hands, wearing a nice suit jacket and dress pants, and trying to blend in with all the reviewers and the academics. And then one of the reviewers stood up, and he said, we're discussing the special access program. And one of the reviewers stood up and said, I could see allowing access to a new medication for somebody who has HIV or cancer. He said, but I can't see allowing access. It's not right, wouldn't be safe to allow access to a new medication for somebody living with rheumatoid arthritis. At that time, I was shaking. I was just like, because this was the first time I'd ever been at anything like this, at a government consultation. And I just stood up and I said, we just published Arthritis in Canada. And if you go, and I can't remember the page now, but I knew the page number. I said, if you go to page such and such, you're going to see that there are actually more people in Canada dying from rheumatoid arthritis right now than from HIV. And you know why? Because they get their medications and we don't. You could have heard a pin drop in the room. And then another role I had a couple of years later was on the expert advisory panel for the COX-2 inhibitors. So there was, some of you might remember the big debacle about Vioxx, and they pulled it from the market, and then they did this big review of them. And so they decided, Health Canada at the time had the Office of Consumer and Public Involvement. This was just before this is pre-Harper. This is during Paul Martin's government. He developed this Office for Consumer and Patient Involvement, Public Involvement. And so they asked me to join this expert advisory panel on the COX-2, me and another patient partner, Pam Monty, who also had rheumatoid arthritis. And so and Lori actually presented at some of our meetings that we had, because we held open consultations in Ottawa, and that was when she talks about me mentoring her. That was probably the first time that we had connected. And so we were sitting at the table discussing the evidence, and the other patient partner and I looked at each other and said, oh, look, if you look at the evidence, Advil has the same adverse events, even more so than what Vioxx did. And so we pointed it out. We said, the evidence here shows that actually ibuprofen's just as dangerous as Vioxx, and yet it's sold over the counter. And, so then Andreas Lipakis, who's was not real happy about having patients on this committee, on this panel. And so he said, and then of course all the doctors were talking and saying, oh, well, patients wouldn't take ibuprofen every day. Well, then we just started, another patient partner and I started laughing. You think people in pain, if they're going to get relief from pain, they're going to take as much as they can get to get relief. And they can go to Costco and buy a bottle of 1,000. And guess what? They're not going to tell their doctor, because taking ibuprofen, it's over the counter. It's safe. They're not going to. So at least with Vioxx, you got a prescription that you get from your doctor that he actually knows you're on it and can check your blood pressure and check your risk factors. With ibuprofen, there was nothing. Well, Andreas Lipakis completely did a 380 degree or 360 from that meeting, and became one of the biggest supporters of having patient partners at the table that I know. And he ended up ultimately later becoming the CMAJ editor, and he's really been, he was on the Canadian Expert Drug Committee as well as one of their chairs. So it was really, that to me was a huge win. I'm going to stop there. Those are just kind of three pivotal moments where I was involved that kind of gave me the motivation and the passion to continue to know that I had a valid place at that table. And if I wasn't there, how much information that they were not getting, and they were making decisions on incomplete information and gaps in knowledge. Therese, I'll let you talk about some of your roles.
Thank you, Linda. I think most recently I joined the Strategy and Sustainability Committee at the Chronic Pain Network, and there was a small group, and there were just 2 patient partners on it, and I was wondering then, like, how am I going to affect this? But the things I learned leading up, because we interviewed different people over a period of months, we met every couple of weeks, and then we met in person. And at the end of that, I felt validated when I was there that any suggestion that I made was being considered. And because I think that I was coming, like, I want to see a legacy left. I think if the network finishes, I want to not, I couldn't believe when we were doing um, looking over the years at everything we'd achieved, it filled the whole wall. And I don't want any of that to be forgotten, because when I first started coming to the meetings, everybody was just fumbling around. Nobody really knew what was happening from one way. And all of a sudden, over the year, it took years for it to make sense and to find where we were going. But uh, I am so glad that I had I was part of that sustainability and strategy program. That was a new thing for me. I've not done anything like that before, but we belong in a lot of spaces that you never dream of. Another area was when I got involved in authorship and wrote a paper, and that was a wonderful experience too. And it doesn't mean the same to us as it does to researchers, because I mean, they have to do them. We don't have to do them, but uh, it's very rewarding. And I think that there's so many doors that we haven't been through yet. But I think as long as we want to be there, I think we need to keep pushing for it. Yeah.
No, thank you so much, Therese. And I shared a copy of the paper that you were talking about in terms of the authorship in the chat, because I think it's some super hands-on practical advice for researchers so they know not to exclude us as patient authors. And
And
that's
one
sort
more
of,
thing too, I just forgot,
no
is that I
worries, go
had a
ahead.
poster at the Piper Day last week. So yeah, my
Great.
first poster.
Yeah, so patient partners can,
Yeah.
develop abstracts and submit them and
Mhm.
present and that sort of thing. So yeah, absolutely. I think it's a great example
Yeah.
yeah, and I guess maybe just to kind of build on this conversation, there was some questions from folks around, where do you find projects? Like where do you see them? Where can you find them? How do you connect with people? And that sort of thing. So maybe I'll go back to Linda and then we'll swap over to you, Therese.
Yeah, I mean, I've been doing it a long time, so projects tend to find me. But saying that, like at CAPA, what we've been trying to do is expand the number of patient partners that get involved in projects. So we've done a number of things. We partnered with the Institute of Musculoskeletal Health and Arthritis for a mentoring project to mentor new projects. So our newsletter, we post on our newsletter that, the different opportunities that are out there. Social media, you follow, you can follow government, you can follow researchers, you can follow institutions and get opportunities through them. Obviously, because I've been doing this 25 years or more, government know who I am, so they will often email me or contact me about a different role to take on, and if I feel like it's something I can do, I will do it. If not, I often will pass it on or suggest that another person might be a better person for that role. So it's just, there's all kinds of different ways to do this. I just recently actually, what I really enjoy, and I haven't done a lot of it, I've just through my own doctor, but I like working with medical students. And so I was on Facebook the other day in New Brunswick Community College, the healthcare professional, kind of stream advertise that they are looking for patients to come in and talk to their students, their medical students. So I sent an email in response to that. I mean, if you follow even like the maritime support unit or the SPORE strategy, you'll see opportunities come, different networks, the chronic pain network. I'll let Therese talk about that one more, but the Evidence Alliance often will put out opportunities for patient partners. I know Lori and I recently, one of the things that bugged me was that we got biologics. Every time we go to a meeting with government, oh, your drugs are so expensive, they cost us so much money. And then, so we have to kind of go back. And I said, well, if you guys had done the research in the last 25 years to see how many joint replacements do they prevent? We don't no longer have hospital beds for people living with rheumatoid arthritis anymore. Our care is all outpatient now. All these things that have come together to say, obviously, if we're getting access to biologics, we're not becoming disabled, so we're not getting long-term disability. Too late for me, but not for the younger people coming up. There's all these things that they didn't look at, and they still haven't looked at. And so we put a query into the Evidence Alliance, and didn't give us a lot of information other than we need to do this research and we have to try to push for it as patient partners because nobody else seemed interested. But really, in an ideal world, before these drugs were approved, if government had come to us and said, or the pharmaceutical company had come to patients, what are the outcomes that matter to you? Well, preventing joint replacement surgery would be a big one for me. Not becoming disabled would be a big one for me. And so those are the areas I think we still need to push. I know there is reform and clinical trials are being under reform and going in, because when I needed Enbrel, there was no clinical trial for me in New Brunswick. I would have had to go to Montreal, and I would have had to go there every few weeks for tests for this and that. It wasn't feasible with 3 kids at home in the state I was in. So, now we're seeing adaptive clinical trials. We're seeing this, but we got to keep pushing because it's so easy for things to slide back and slip back.
Yeah, no, thank you, Linda. Yeah, Therese, I don't know if you've had any,
Yeah,
or have any
well,
advice on how to find projects, or maybe they
yeah,
find
I,
you.
I do actually. I mean, yeah, the same with me as people do reach out to me now. But one of the things that we wanted to do as the patient engagement committee at the Chronic Pain Network was to try and make it easier for patient partners to find positions. And it's called Pain Connect, and it's matching patient partners or potential patient partners with researchers, clinicians, policymakers. And you just sign up. It's very easy. It's easy to navigate. There were a few of us. I was on it. Janet was on it from CAPA. And we wanted to make sure it was going to be easy to navigate because we aren't all tech savvy. But so you just sign up, put your name, your what you're interested in, what your conditions are, and they send out newsletters quite often. There's also one, it's called PAN, I've seen, and they always have some opportunities going on, and Pain Canada is another. So there's lots out there, but it's just you don't find out until you have meetings like this, and we can share that information with you. So yeah.
No, sounds good. I think, and I
Mhm.
put like some of the links to things in the
Mm.
chat, and we'll make sure those end up sort of in the references, so you can connect to those. I'll
Yeah,
do a
and we
little
share them
I'm
plug.
with
just going
you,
to
right?
jump in.
Yeah, yeah.
Jump
Yeah,
in with one more opportunity, because I
sure.
know if you sign up for like different the non-government organizations, I mean, like CADIF has call out sometimes for a patient representative on their committees. Healthcare Excellence Canada has a newsletter, and they're getting lots of opportunities. So when you sign up for these other organizations newsletters, then part of that you get the opportunities that are out there as well. So.
Yeah. Yeah, and I might add too that we just have like this base camp community. So if any of you are interested in sort of being added to that, Basecamp is just sort of a tool, but I try to share things as they come up, right? And sometimes people or groups approach us as an organization, and so I'll put them in the newsletter too, but often I just kind of share them internal. I'll call it internally. There's like a gang of about 40 of us on there. So, and like it's just kind of sent to you. There's no pressure in terms of, getting involved. But again, we're just trying to show people like what's available out there, and people pick and choose based on their interests and what they're able to contribute to at that given point in time, right? So So anyways, I thought I'd highlight that. I don't know if you two have anything else before I move on to the next question. Just let me know.
No,
No?
I'm good.
Sounds good. And I thought I might shift to, there were some questions around sort of how to share your lived experience, right? Because for us, right, it comes from such a, well, first of all, it can come from a point of frustration. I'll speak for myself that, this is like a big reason why I do this kind of work. Mistreatment, anger, inevitably, right? And so how do you like, I think there's a lot of expectations on us around like packaging it up, right? And finding the right ways to convey that. It's not always easy, it's like there are some things that I won't talk about anymore, like my pregnancy experience, for example, because it's just like it'll forever be raw. And I've I'm I'm content with that, right? But anyways, I don't know if you folks, because you've been in so many different spaces, like, is there any, I don't know, any words of wisdom around that? So Linda, I'll go to you first.
Did you say Linda first?
Yeah.
All right. Well, I mean, certainly there's been a lot. I've had a lot of experiences, and I've shared them, many many times. I remember the first article I did. It was on the Arthritis Society magazine back in like 1990. Well, it would have been 2000 because I had already gotten Embral. And I remember doing the interview with the person and sharing my story, and then they did this whole big piece on me, and it was like January, and it was freezing cold, and I had to be out there in just a shirt, and I was shivering to death. And that was like, just physically, that was one of the hard things to do, but emotionally as well. I mean, it's you're trying to relive some of the worst times of your life. I mean, like I traveled to Toronto for a C1 to 3 spine fusion. It was awful, and each surgery was traumatic. Living 3.5 months in hospital in pain was difficult. Just like all these things, and you're sharing it. And I've shared, even on TV, I've done different media outlet things, especially when we were lobbying for access to the medications. We had to put ourselves out there. I mean, we're seeing now where most of our patients, we hope that a lot of our patients being diagnosed now get access to the treatments and the medications and have increased awareness, and they're benefiting from that. But back then, we really had to show government what this disease could actually do to your body. Now in New Brunswick, we had a health minister right around that time when we got the catastrophic drug program, who actually had psoriatic arthritis. His name was Brad Green. And he came to one of the Arthritis Society meetings and spoke and actually said he admitted he had psoriatic arthritis. So we knew we had a bit of an ally there as well. But it's always, I mean, recently I did an interview for a research interview with the chronic pain community on a research project on how chronic pain impacts your life. And, like they were amazing. I think it was probably the best research team for, trauma that I've ever met. I mean, right before the interview, they gave you resources. They said, they warned you. They said this could trigger, traumatic. We want your phone number. We want your address in case we have to send help to you. I mean, it was really, really unbelievable what they did, and followed up with me afterwards, like, a half hour after the interview, saying, how are you doing? Are you okay? Because it's always traumatic. And then, these are terrible experiences that you're hoping you share so that they don't happen to somebody else. And I guess that's what I try to think of. I think if I'm sharing this, maybe somebody else, it won't, this horrible experience won't happen to them.
Thank you, Linda, for sharing that. Therese, I don't know if you have anything else you'd like to add or.
Yeah, I just think that if you're going to put yourself out there, to just be sure that you're comfortable with what you say, that it's not going to come back and hurt you. I mean, I have been an open book, and I have a really traumatic past. I mean, I lived on the streets for years, and I did a lot of things that aren't really great or I'm not proud of. And so I don't share that really worldwide, but I find that I'm okay in certain groups to share that, because I think that if it can help just one person, then it will, that will help me basically. It helps me make sense of some of the things that have happened. But I think you need to protect yourself. Don't overextend yourself. Don't do something you that's going to harm you. Just be very, very careful how you package your story. Yeah.
Yeah, for sure.
Hmm.
Yeah, I know. Thank you. Thank you both. I think it's a delicate balance, eh? And I think knowing yourself and like you said, Therese, like what you're comfortable sharing, when, in what context, and with whom is super important, right? Yeah, anyways, thanks so much. And if anybody has any resources, right? There's also a comment in the chat in terms of, is it too raw, too soon? You're from Colleen, it's, uh, something to reflect on, almost some reflective questions for ourselves, right? And only we can answer that, and that sort of thing. So, I think, and I know we're about 13 minutes before the hour, so I think there's time for like hopefully one more, maybe two more questions. But in terms of the questions I got from folks in the registration, just talking about, what are some the most effective ways to speak up, right? It's kind of relating to how you package your story, how you share, when you share. I know it's something I've been learning myself, right? If you're sitting in a meeting and maybe they're not getting the point, is there like some way we need to like learn how to convey it, or is there like some advice that you've seen, even if you just want to use like a case study? So I'll go to you, Linda, because I'm sure, well, both of you probably have lots to share on this.
Yeah, I'm thinking, uh, trying to think of the answer for that. Just can you repeat it again, just to get my thought clear?
Just some ways to get a point across in a situation where you don't think they're necessarily getting it, right? In terms of the concerns you might have as a patient.
Yeah, and I mean, this is really important because I mean, in the beginning, one of the things that government and researchers and clinicians used as a reason that patients shouldn't be there was it's too traumatizing for them, and they're just going to get upset and they're going to cry and they're going to they're just going to derail everything because they just can't handle the input. And I think fairly quickly we kind of dispelled that, and it was obvious from the people that were contributing like through the years that yes, we can get upset and can be angry, and sometimes that's justifiable. And in the beginning, because we had to fight, and kick the door down pretty much to get in. You really felt that responsibility. At least I did. I felt like, here I am, one person trying to represent everybody, and one person cannot do that. It's just really hard. I could represent my own experiences, and that's what I do. I don't, if I don't know something, I don't pretend to know anything about it. I will say that's not an area that I know anything about. That's not my area of expertise. So it keeps your credibility. I protect my credibility. I share my lived experience. I'm not a data analysis. I'm not a researcher. I am just a person who has lived with rheumatoid arthritis for 45 years and have experienced just about any negative consequence of this disease that a person can experience. So, and a lot of it was avoidable. I mean, if I had gotten access to a biologic even 5 years sooner, I could have prevented probably 10 surgeries, because most of that damage happened from like 1998 to 2000, as my body, had just kind of starting to give out on me. Now, I have so much, where I have both knees, both hips, both shoulders, an elbow, an ankle, both, my hand, my feet. I've had so many surgeries, and many of them could have been avoided. So that's what I do. I just try to share my own personal. I try to be diplomatic and not to blame people, because people don't know what they don't know. I mean, back in 2000, before I got involved, well, maybe not 2000, probably 1999, when I started to realize that maybe all these people making decisions really didn't know everything that I thought they were supposed to know. How could they? They can't know everything about every disease. You just can't. So, the public perception with arthritis wasn't a serious disease. And so we had to dispel that public perception, right? So you just have to realize that you have, and Teresa said it as well, you have a valid place at that table, and you have something to contribute, and you just want to try to get it across in a way that you don't want to point fingers. People aren't, government doesn't purposely want to make us sicker. They some of their decisions do, but they don't. That's not what they set out to do. And I think I've found that out mostly in the last 25 years, that generally the system wants to help. It's just sometimes there's barriers in place that prevent that.
Yeah, for sure. Yeah, how about you, Therese? Any, thing in terms of when someone's just not getting the point, like any
Yeah.
advice in terms of what to do?
Yeah, I think that because I mean, we don't earn a salary. This is not our job, but we do this because we're working for the greater good. I know that I work for the greater good, and the most of the patient partners that I've met are all working for the greater good. It helps us put our own illness on the back burner for a little while we concentrate on something else. And I feel that if you're it's happened to me. I felt I was banging my head up against a wall, and I had to look at what it was doing to me. It was tiring me out. I felt I wasn't getting my point across, so it was okay for me to walk away. And because it's not working on anybody's end, and yeah, it's just knowing when to do that, and looking at why we're there, getting real with us, getting honest, and does it really need to be this hard? No, it doesn't. So just walk away, I think. Yeah.
Yeah, no, for sure. I think it
Mhm.
kind of goes back to what you were
Mm.
saying before too, around like just kind of
Mhm.
knowing yourself, and when like, you kind of, I don't know about you, but I get this sort of feeling inside when it's like, and when that
Mhm.
feeling starts popping up, it's like, I think it's time to walk away. And
Yeah, it doesn't happen all the time. It's not, there are some fabulous
yeah,
experiences, but when you're not getting anywhere.
yeah,
That's a quality you learn, right?
absolutely.
So yeah,
Absolutely.
and
Yeah.
we have to put ourselves first. Yeah.
Yeah. No, absolutely. Very, very, very good words of wisdom, Therese. And so I know we've got about 5 minutes left, so I'm not sure we'll have time to get to another question fully, but I will maybe take a look at, there's a couple questions that were remaining from that were submitted. So maybe what I'll do, Linda and Therese, is get you to maybe write an answer in for those ones we didn't get to. So one of them is advice for people who are new to patient engagement, like, and they're trying to engage patients in their work. There's something around like meaningful patient engagement and time management. So if in terms of managing the multiple commitments, right? Because, you kind of get involved and suddenly it becomes very like a lot, right? Or it can get to be a lot. So maybe I'll take those questions. And if anybody has anything else they'd like, Linda and Therese to answer, just email me. I also have a survey in terms of giving us your feedback on this whole conversation, whether it's helpful to you. Just give us some feedback, and maybe you could put any outstanding questions you have in this survey. Um, so then I can take a look at them and try to do some sort of compilation afterwards. Anyway, so thanks for that. And thank you, Linda and Therese, for, participating and being so open and sharing of your experiences. We have so much to learn, just think of all the years of lived experience and contributing to things. Like when you put it on a scale, it's probably like, 70 years or 60 years of expertise kind of being brought into the room, into the patient room, so to speak, as we've named this webinar. So really appreciate that. And yeah, like I said, sort of openly sharing things with us. I'll just share a couple slides, mostly just to sorry, I know I'm always on current slide. So that's the link to the survey here. I know I put it in the chat, but would appreciate, any feedback you can provide on that. Of course, like I said, can subscribe to our newsletter. Let me know I'll put my email in if you'd like me to add you to Basecamp, and that it's sort of more informal community that we have of people. So I'll put my details in there, and I'll be sure to add you and connect you in. We also have another webinar coming up that is focused on getting a diagnosis of arthritis. So maybe less as a patient partner, but still, I'd love to say that like a lot of these skills are applicable, whether we're like trying to get care from our doctors or healthcare professionals, as well as in other realms. So it's part of our lived experience series, really kind of recognizing how much knowledge we have amongst ourselves in terms of navigating the healthcare system, getting a diagnosis of arthritis. So super pleased that actually some of those speakers are in the patient room here today. So Nazret and Kim are here, and Lucy, but it'll be facilitated by one of our board members, Jenny Lorca, who's based out in British Columbia. And then we brought in one healthcare professional, Dr. Rashid Kashani, who is, happy to be sort of contributing his experience as an occupational therapist in pediatric and adult care. So we'll have that. You can register for it using this QR code, or I will also put it in the chat just in case, you're not a QR code kind of person. So, yeah, thank you everybody so much. And hopefully we'll see you next month. Hopefully I'll see you sort of on Basecamp or whatever, but have a good rest of your day wherever you're located here in Canada. So thanks so much.
Thanks, everybody. Bye.
Bye.